It always makes me tired to listen to the things I do. Thank you for the nice introduction, and thanks for listening to this again. I did this yesterday for psychiatry, so Rich and Lisa are going to have to listen twice to this presentation. I'm really honored to come here to speak to you all because in Utah, integration happens. Anybody in integration and collaborative care knows that you all do it. You do it right, you do it better than some other places. So I'm honored to speak about one little thing that I've done in Western Pennsylvania and just talk about where we've come and where I think we're going. And if anybody has any questions or wants to jump in, I'm not opposed to being stopped along the way. As I was sitting there, I was remembering I put that yellow brick road up there, like, are we on a yellow brick road to collaborative care? Hopefully the other side there is really something and not what was in the movie. So, and this is my basic outline to keep us on track. I think these objectives are fairly similar to the ones that are on your objectives for today, really to talk about our behavioral integrated health system and understand how we've used mechanisms to improve integration. Anybody that is a pediatrician, is a primary care doctor, is a psychiatrist, knows this. Probably the primary care doctor is better than psychiatrists, that a lot of kids have behavioral health needs. Most of them are seen in primary care. You can even see data that says up to 99% of them are seen in primary care, and very few of them ever get to specialty care. These are numbers that, despite lots of work by many people across the US, haven't changed and are probably unlikely to change with the number of psychiatric providers that we're training across the US, and that's a problem. So why integrate behavioral health in medical systems? And I truly believe, and I think the data bears it off, that better behavioral health is equal to better behavioral outcomes. When we started on our process of integrating, what really became clear to me is that getting from primary care to behavioral health was like walking across a long bridge like that. And I put that up there because the number of anxious people we identified that would have never gone to behavioral health was really impressive, and they'd never walk across a bridge like that. So when we started, my very intelligent, very on-the-ball mentor said they weren't sure it was going to work. And then they weren't sure if we were going to take patients away from them. And we actually identified a whole new group of patients, hopefully giving them early interventions and better outcomes. So I'd like to talk about terms first because I think collaboration and integration is a fledgling field. It's not 50 to 100 years old. It's really 30 to 20 at most. And we're still sort of agreeing on what definitions mean. So I'm going to say today what the definitions mean for me when I speak so you know what we're talking about. So first, I like to back up and talk about collaboration from like a non-medical perspective, but I think this works for when you think about collaboration. This is a process to reach goals that cannot be achieved by one single agent, has common goals and responsibilities, sharing responsibility for reaching the goals, and working together to achieve these goals. Hey, I have a question. I can't see the picture on the screen. Does anybody know how to get me to do that up in front of me? Because I feel like I'm looking here instead of looking out in front. Thank you. Okay, I'm going to keep moving, but I feel like I'm looking in the wrong direction. So integration is actually the transformation of a system in order to change outcomes. So not simply increasing access through co-location, but actually changing the system of care, which is truly what Intermountain has done and is what we strive to do every day in our system. So also non-medical definition, but I think fits perfectly with what SAMHSA and other agencies have said about integration, that you move towards networking, coordinating, cooperating, collaborating, and integrating. And this is the collaboration continuum where fully integrated is the end of the continuum. Although I would not sure whether that's the actual goal, like everyone should get to the point where they're in a fully integrated system. Not every system may be able to do that. Anyone that's involved in integration has probably seen this slide, but I put this up here to note sort of how complicated it can be to think about. Thank you, perfect, to think about what integration is, and that you can move along a continuum from minimal to full collaboration in a transformed, merged, integrated practice. I think it's reasonable to say that Intermountain is at level 6 here, where they are not just in the same place, but truly have resolved many of the systems issues related to providing behavioral health. It's interesting that despite that, I'm seeing the eyes roll because it's just not that simple, right? You can get there and realize there's still a long yellow brick road ahead of you. And there are differences in doing it for adults and children, although the basic concepts are the same. Politics are local, integration is local, and there's difference in terms of what people you're working with. We often say our system is a level 4 to 5, maybe in some of our advanced practices pushing towards a level 6, but that the systems we have in place are more in the level 4 to level 5 area. So a collaborative care model, which I also often call with the 2 big C's, when I talk about that, is an evidence-based intervention for providing integrated care. Like in psychiatry, we often talk about what are the evidence-based interventions. Are people giving the therapy interventions that are evidence-based or just sort of hanging out with someone? In psychiatry, we often talk about cognitive behavioral therapy as an evidence-based intervention. Collaborative care models is an evidence-based intervention for integration. And it often involves a PCP, a care manager who can be a nurse or a therapist, who provides not only therapeutic interventions, but does active screening, monitoring, follow-up, and manages a registry, which really you all know how to do that here, and we're still working on how to do that the best. And then there are often psychiatric consultants for the more complicated kiddos to help them figure out what they need and to see them if need be. So why specifically integrate in pediatrics? And I'm probably preaching to the choir here, but the fact of the matter is parents are more comfortable coming to their pediatrician, to their primary care doctor with developmental behavioral concerns than they are going to a random psychiatrist somewhere. It's really the first person that parents go to with questions about basic behavior, sleep, appetite, food intake. And unfortunately, when problems occur, there's often a delay in getting services. And I think there's pretty good reason to believe that delay equals poor outcomes. And that when you place services, even co-locate them in practices, there's reason to believe that that will decrease the time of access. And if you can increase access, maybe you can decrease the long-term morbidity associated with some of our illnesses. And probably most importantly, integrating behavioral health services in pediatrics has been proven to be effective. So there's a ton of data on the adult side about the efficacy of collaborative care models and integration, but there's also an emerging and very clear data set in the pediatric world. Put this on here just to show how complicated it is to put together a review article on the integration processes. Jonas Sarno did a fabulous review of the evidence base that's out there for pediatric integration and mostly collaborative care models, and was able to break down both the characteristics of the systems and the process of care that are required for a collaborative care model, remember those 2 big C's, or an integrated model, which isn't the specific evidence-based intervention, but is providing something along the continuum of integration. And the meta-analysis by Sarno found that research studies that had mental health treatments performed better than substance use treatments. Those that did specific treatment models, so an identified condition and treated it, had better outcomes than prevention models. Collaborative care models, so remember those 2 big C's, had a moderate to a large effect size on outcome, which is pretty impressive. We love to see that in behavioral health, but in any medicine. And integrated care models had a small to moderate effect size. It's an emerging data set, and I think some of the reason for those mental health and treatment models performing better than substance use and prevention are that the outcome measures that you look at are clearer. So if you're looking at ADHD, it's very clear what outcome measure you're supposed to look at, and it's very immediate. One of the best studies on ADHD, they really improved the amount of stimulants that kids got. Well, you can see that outcome like that. We all know that, right? But a prevention, that's going to take a lot longer to show prevention effect. And it's not even clear always what outcome to look at. And then substance use treatments, and we'll talk a little bit about that later, are even harder to show the outcome in the short term. So Children's Community Pediatrics Behavioral Health System. And just to give you a little bit background, as I said, collaboration is local, so you need to understand our system a little bit. So about 10 to 12 years ago, our pediatrics group did a 10-year planning session and decided that what they needed more than anything else was access to behavioral health services, and they wanted it in their practices. They felt that times were changing, and I literally had one doctor say to me, if we can't do this, we will be obsolete. I don't know how much you guys are all experiencing the urgent care phenomenon around here, but they really saw that a lot of what basic things they thought were pediatrics were being taken over into urgent cares, and that if they didn't start, and that vaccines had really changed the world, and that if they couldn't take on behavioral health better, that they may not have a role in the future. So Children's Community Pediatrics, which is the group that came to Western Psych asking for us to help them, is actually a for-profit subsidiary of Children's Hospital of Pittsburgh. It's over 40 practices across Western Pennsylvania, each their own little fiefdom that have been around forever, that bought into becoming a part of Children's because of the infrastructure. But they are still all their own little fiefdoms, and they're for-profit. Which is really important. So when we started, we were basically tasked with that we had to quickly become financially sustainable in a market that is still fee-for-service. They currently have over 200 primary care physicians, 245 1,000 active patients, and cover 13 counties in Pennsylvania. But there is centralized oversight and support for billing and for quality improvement initiatives. And there were over 600,000 office visits in 2015. And then Western Psych, which is where I'm actually employed, is that's our huge hospital. But we have over 400 inpatient psychiatric beds, more than 90 ambulatory programs. We actually tried to count this recently, and I think it's over 100 across the lifespan, not just peds. And we're really one of the largest behavioral healthcare providers affiliated with an academic medical center in the country, probably in the world, with a lot of great robust research and evidence-based clinics. But our pediatricians felt like they had zero access to any of our services, even though a couple of them are literally less than a mile from this building or less than a half mile from our outpatient building. So despite having literally the largest hospital in the country other than one on the West Coast, they felt like and we don't have the most amount of people, actually. Pittsburgh's not that large. They felt like they had no access to these services. And then Children's Hospital is a large hospital as well, that began as a very small hospital in 1890, but has grown to be consistently a top 10 hospital in the U.S. News and World Report, with a lot of inpatient stays, observation stays, emergency express care, and surgical procedures. And they even have surgical procedures going on in multiple other countries at this point. And we're beginning that about 10 years ago when we started. They had 3 therapists when we started, and they weren't all full-time, with not a lot of oversight or support. So I used to have a slide that said big hospital, small therapy program. Very good therapist, actually, which was interesting. So really great therapist, but all sort of doing their own thing, trying to not get isolated in a large pediatric hospital. They also felt like they had no access to Western Psych either. So if kids got sort of out of their ballywick, they'd send them to the ER because they didn't feel like there was any ambulatory access. So this is the evolution of our service, and I do this to remind myself that it didn't start with us, that we had a lot before we really combined with Children's. And Dr. Spock, who wrote the book on parenting, was actually at University of Pittsburgh in the 50s. John Camp, who I really believe is the father of integration in pediatrics, really worked through the role of a nurse clinician and a nurse clinician in CL and outpatient in the 1990s. Despite all of that, by the mid-2000s when John left, we didn't have a lot of a relationship left. We had a small CL service that was working very hard, but constantly arguing about financial support, not having enough psychiatrists, could we do all the consults that came in, and really not a great relationship between Children's and WIPIC, despite us actually being across the street from each other. So building our program. There were, as I said, some models of integration in Western PA, which I need to talk about because they're important. So CCP Armstrong Pediatrics, there was a CRNP in the office with an interest in training in behavioral health who had direct supervision from a child psychiatrist. She is currently sort of at the head of her field for DNPs and is training a lot of DNPs in Western Pennsylvania to provide behavioral health care. When we first started, the thought was from the pediatricians that we would expand the DNP model, but we couldn't find enough to do it. Now the problem we have is that we don't pay them enough, but at the time we couldn't find enough to actually do that. That model, which I actually worked in as a medical student, started out with separated physical health and behavioral health records, with her actually being employed by the behavioral health center. By the time I was a faculty, she was completely integrated, and there were a lot of good outcomes, but we couldn't find enough of the people with this training to do this job. We also had research programs going in Pittsburgh that fed into that Sarno analysis I spoke about before. So these were free to the practice, but time limited. The pediatricians felt they had a limited scope, and the fact of the matter is that at the time, we didn't know whether they were effective. Now we know they were effective, but they weren't financially sustainable. And they're still actually not with the current structure we have for financing, although there's reasons to think that might change. So there'd been some experience with collaboration, enough for our pediatricians to know that like engaging with behavioral health could help. They just didn't know how to scale it. So I was lucky to be a part of a group that got together, a really empowered leadership group that included both clinical and administrative, psychiatric and pediatric stakeholders at the table. So people on the ground who were actually doing the work, and people in administration who could actually move the systems when they needed to move. And I've done a bunch of initiatives since then, and I think the reason why this was so successful is we really had the right people at the table. And I didn't realize how lucky I was at that time. It's hard to do things and get the right people at the table interested in moving in the same direction. We sat down and agreed on a mission statement and primary goals from the beginning, and our pediatricians were really clear that their mission was access. They weren't really sure what treatment meant or what effective treatment meant, but they wanted to get someone in to see a provider, and they wanted to have access to a psychiatrist if things didn't go well. So they felt the black hole between pediatrics and behavioral health had to go away, but they didn't just want a therapist. They weren't going to do it without psychiatric support. Even though I think they wanted to do it without Western psych, actually. They just wanted a psychiatrist. We identified clinicians and administrators that would drive change at the practice level, and every time we go into a new practice, we do this. We agreed on roles and clinical pathways. We identified first early adopters, so you had to find practices that were interested, able, and willing to make change, and champions at each level in each practice. So after we agreed on access, we sat down and put together this. So the lead therapist, myself, and the pediatrician wrote this. And we agreed what's already happening in the office, what did we think a collaborative care team could do, and then what needed to go to a psychiatric facility, because it seemed that part of rolling this out needed to be more education about what could happen in a pediatric practice, what we agreed we should be doing, and then what needed to be sent somewhere else. Because there was general worry that if a therapist showed up in the office or a psychiatrist showed up in the office, that the pediatricians would just want to send everything to them, especially the acute, worrisome kids. So we really needed to agree and present as a team to all the pediatricians. And if you'll notice, a lot of these words, these aren't all psychiatric words. These are words that I think you could give to families and they generally understand. My lead therapist specifically is very proud of non-behavioral concerns, which we use to educate people about things that might seem like something you'd want to send a therapist to, but might require some other provider, like a custody evaluation might provide a custody evaluator. Child welfare issues, learning or school evals, or financial or housing things. That's not a licensed clinical social worker, that's a social worker or a care manager sort of thing, depending on what your system calls them. So, and then we put together indications and exclusions. So what we thought should be sent to us and what we thought might need a higher level of care. And again, if I could do this, again, I'd get rid of everything in exclusions other than complex psychiatric illness, because we've basically taken care of autism, developmental disorder, mood disorders, even some severe mood disorders that get better quickly we can take care of for short periods of time, and substance abuse. We've done some work with that as well. Because there's such a power in a therapist that works well with a practice, being able to use a chronic care model with their providers. There's just such power in it, and really being able to refer people to get an evaluation to figure out what they need, especially for those that might need a higher level of care but drop between A and B, to then know that you had that psychiatric or that therapist evaluation, who then when they show up again can do some more motivational interviewing to get them to the right place, because we're never going to solve the problem that a lot of people aren't ready for behavioral health treatment. But what we can do is figure out what we think their needs are and just keep making sure everyone on the team is clear about them. So there's not one person on the team saying like, well, I'm not really sure you need that. We need to all be on the same place. And so then we identified what care pathways were. So we said the pediatricians were already informally screening for behavioral health at well child checks, but there was reason to believe that doing formal screening would be a good idea, and our health plan was going to start paying for some of them. So at this point, we've got a PHQ-9, EPDS, which is for postpartum depression, an autism screen, and a substance screen, which I'll talk more about later. We said once you refer to the therapist that they'd evaluate and provide treatment, refer to a higher level of care, or collaborate with a psychiatrist. Psychiatrists would do the same, evaluate and either refer to a higher level of care or provide short-term treatment with the team. There's no rocket science here, except for continually reminding people that like every step of the way is an evaluation. Like, is this the right level of care? And maybe even every appointment is an evaluation for some kids, right? So are we still at the right place? Excuse me. Essentially, the team is everybody the patients might come in contact with, and you really need to be aware of all of these team members when you roll out into primary care offices, because anyone that doesn't believe in mental health or had a bad experience with a mental health provider could potentially upend the system. So, one of the reasons I think we were successful, that I think all integration is successful, is it's able to break down barriers and stigma. We started in separate records, and within 2 years, we were able to integrate our records. So we have a completely integrated record for our outpatient, and that, as my lead pediatrician says, was a game changer for them. And I'm happy to say that 12 years later, we're going to have an integrated outpatient record too, which was a little bit of a harder sell, but all of our psychiatric things except for substance use are going to be integrated in the same record soon, even in Western Psych. We also continually talk about, and we still do, this patient is a member of your practice. They check in just like everyone else. They schedule just like they're scheduling with the PCPs. There's no handoffs. This is not your patient or my patient, it's our patient. So we do need to continually to go back to this. I think more than once we've had practices remodel, and like someone that's involved in the remodeling will be like, oh, we'll create our own little section for behavioral health that'll have a separate door. And so every time we hear about remodeling, somebody's got to get in there and remind them, like, no, we don't want a separate door. We want everybody to be the same patients. It amazes me after 12 years of doing this and how integrated we are that people still think that. And then the other thing that really allowed us to succeed was the shared resources. So CCP already had these researchers doing billing for the medical side, but we cross-trained them in how to do behavioral health billing and credentialing. So that's really a sticking point for a lot of places that try to do integration. It is hard to bill on behavioral health, and it takes a lot of work. So we have a centralized support doing all of that, and they're actually now doing it for other places too. And then we were able to share supervision and education from our psychiatrist and our lead therapist. And we continue to have an exec committee that meets every other month to get feedback directly from the pediatric practices and talk about new initiatives. So currently we have 24 licensed clinical master's level therapists in the primary care settings, embedded in 23 locations. We have primary care sites, so literally where they're practicing together. And then we have regional access hubs where people that don't have a therapist in their office because maybe they only have one or two pediatricians and they can't support a full-time therapist, they can refer to someone in our hub. Our children's hospital is actually also very dedicated to the community, so we take referrals from the community in those hubs as well. And we really focus on providing brief empirically supported interventions. We have approximately 5 full-time equivalents of child psychiatrists that are split between our outpatient care that I just talked about, TIPS, which I'll talk about next, I believe, or soon, CL, our subspecialty clinics, which was the next place that we went. So we have actually over 40 therapists between our subspecialty clinics and our integrated clinics. And we do therapist supervision meetings twice a month that are led by the therapist and the child and adolescent psychiatrist. So that piece, the supervision piece, actually required a lot of communication and discussion amongst the practices. So remember, our practices are for profit. So they want every single second to be used for patient care. Now, behavioral health care people like to have weekly supervision for at least an hour, like to have additional training on top of that. So we really got to this middle ground where there's twice a month and they have access to their lead therapist at all times. But when I speak to some of our behavioral health providers, they're a little bit annoyed that they only meet twice a month and they feel like maybe that's not enough. We're not a place to bring people that are young that don't have experience yet to learn. They have to already know how to do diagnosis. They have to be flexible and be able to think on their feet and offer interventions like at the very first visit. So we did have the benefit of some data, nothing like Intermountain has, but before we started, as the medical director, I was able to perform interviews with families about what they wanted for behavioral health services, and not surprising, they all said they wanted to start with therapy, but get access to a child psychiatrist as soon as they thought they needed it, which is exactly what the pediatricians wanted too, I think reflecting what their parents were asking for. We continue to use patients surveys, and when we do new initiatives, we bring family members in for content in addition to like research content experts. In fiscal year 16, we had over 17,000 visits with our show rates consistently near 95%. That looks amazing to behavioral health settings, but it's not amazing in integration. Essentially, integrated show rates they directly usually reflect whatever the outpatient show rate is for the pediatrician. We have been able to get kids younger than the traditional behavioral health setting, with the median age of youth in our setting in 13 compared to 15 in traditional behavioral health services, with 2 peaks in referrals. If you look at a referral peak graph for a traditional behavioral health setting, it just it starts out somewhere around 3 or 4 or 5, depending on what service you're in, and just goes up and up and up and up. Ours peaks around 10 and 13 and then peaks again at 15, showing we're definitely getting kids earlier than a traditional health setting. And then our health system put some data together and showed that we were saving money and for the system, and that the efficiency was 6 times greater than the reduction in the annual cost per patient for CCP. So they got really excited about that and expanded, which I'll talk about next. In the meantime, as we continued to grow, it became clear we were never going to have enough child psychiatrists to do all the psychiatric management for the kids that were in our system. So we got a very small grant to do a 4-part lecture series for our pediatricians on how to diagnose depression and anxiety. And we worked, as we always did, as a collaboration with our lead pediatrician and myself. And basically, he said, I want to do this. I think this makes sense. I will not do this without a lawyer. So they wanted a lawyer to come in to talk about the potential medical legal risks of treating depression and anxiety in their settings. I would have never done that on my own. It didn't even, like at the beginning, it didn't even make sense to me. But it really resonated with our community pediatricians that were out there on their own, worried that if they started doing SSRIs, especially we're talking now 5 or 6 years after the black box, that they would somehow get sued. So we had a great collaborative discussion with a lawyer that's become an expert in behavioral health since then, actually, about one, how rarely primary care pediatricians get sued, frankly, and 2, that if you have a clear safety net around you, that you're in a much better place if you do get sued. So they started using the term safety net during that presentation, and my lead pediatrician uses that every time we talk about this now. Remember, you have the safety net, so this is why we can move into the next initiative that we want to do. And that term safety net has really taken off, and I think really helped us grow. So this was well attended despite the fact that it was at night and in the winter, and 75% of the pediatricians said that their training would change their practice. We did a chart review then and saw there was a significant increase in the use of evidence-based interventions, mostly referrals, like identifying that they thought depression and anxiety was happening and referring for CBT. And then we looked at pediatric acute care visits at the request of my lead pediatrician. I told him there's no way we could show a change, like no one's been able to do that in well-controlled studies, and we were far from a well-controlled study. But we did see a decline in acute care visits in the year following engagement with our services. We think mostly attributed to sort of the psychosomatic kids, the belly pain, the headache kids that were going to behavioral health instead of. So it's a little bit of a shift, but at least they're getting the right service instead of an acute care visit that can't really serve their needs. And then our health system got together and looked at Western psych visits and visits to our specialty behavioral health services, which interestingly cost more money, and showed that they thought a lot more kids were going to specialty behavioral health and a lot less kids were being hospitalized in our system compared to like systems. And that by just a simple 1.2% decline in referrals in 2011, that potentially $2 million a year had been saved. This is when I learned that when you have big numbers, small changes make a big difference financially. And then because of that, we won a bunch of awards, which was nice. And I got to go talk to other people, and I got to get to come here and talk about what we do. So we started in about 2000. Our first meeting was in 2006. 2007 was when the economy crashed, which made our sort of, we had to think even more thoughtfully about the financial piece. So we moved, our children's hospital paid for the upstart of this project, but we had to get it offloaded to the pediatricians even faster because of where the economy was going. And then we also took a look at hiring some of our triple board people. For those of you who don't know, they're psychiatrists, adult psychiatrists and child psychiatrists to be part-time pediatricians, part-time psychiatrists. So even though we couldn't get approval for the system at the time for a full psychiatrist, we were able to sort of split finances that way. And it's what triple boards want to do. So that was a nice thing. And then by January 1st, 2014, we moved over to complete practice-based employment of the therapist. So every single one of our 20 therapists are employed directly by the practice with supervision and quality oversight from the behavioral health team. So we continue to be a collaboration, but with ownership truly by the practices. So what are the lessons I learned is that clarifying mission and practice level buy-in is just very important, and that the support with physician oversight was also very important. So practices that had a great administrator, but the physician didn't say, like, this is important to me, the physician lead didn't make it happen, they couldn't get it to work. And reverse. So a great physician without good administrative support couldn't get it to work as well as other practices. And we obsessively look at how much our therapists are being used. And you can, just from looking at utilization, you can guess which practices are struggling in one of these areas. And then I think really the joint psychiatric and pediatrician leadership really made a difference. We have since then expanded into other areas, and the areas where there's like a psychiatrist that's leading it and no primary care physician or no specialty physician that's got buy-in, it's almost like replicating behavioral health. Or if you have like a specialty pediatrician or especially say OBGYN doctor that's really interested, but they don't have a partner that's a psychiatrist, that also doesn't work. So the relationships matter is what it comes down to, and having the right experts there. Also being really attuned to the isolation of providers. So it is true that even though we all do behavioral health, whether or not you're primary care or a psychiatrist or a therapist, there are some differences, and putting a therapist in a practice has the potential to be isolating. So we really stay attuned to that and really work hard to keep them together. People need to keep coming to our twice-a-month meetings. We have other meetings in addition to it. We send them for trainings. We really want them to feel like they're part of the larger team and not just out on an island in a pediatric practice. And so they also stay in tune with what's changing in the mental health field, and they don't sort of get off on their own doing things that might be evidence-based. The other thing that has become increasingly clear to me is the importance of staying attuned to changes at the practice level, right? So what I said earlier in this slide about making sure you had strong physician oversight, strong administrative support, if the practice changes leadership, and things could change quickly. So we review that on a regular basis. And we actually have our therapists meet once a year to talk about how the things are going in their practice and which pediatricians and primary care clinicians are moving forward in terms of their behavioral health and how to move other ones forward as well. So using like a motivational interviewing approach to helping our primary care doctors continuing to move forward. So other accomplishments, we were successful, which was awesome. So Children's Hospital, usually things move from inpatient hospitalization to outpatient, or from adult to child. We went completely in the reverse. So we did well, so they moved our outpatient model to our subspecialty clinics, which was fun. And then we did well there, so then they moved it to the adult outpatient, and now we're in the adult subspecialty clinics. So really replicating the model across our entire system, which covers all of Western Pennsylvania. In the child side, these are the clinics we're in. These are all subspecialty clinics except for that Family Care Connections one, which is a clinic that's actually in the community, and home nurses do visits for families that are at risk. The entire pediatric service line completed over 26,000 patient visits in fiscal year 2016, and I think we're going to be up substantially in the upcoming year. And the subspecialty clinics, we have a mix of psychologists and LCSWs. So there's the picture of our growth again. You'll see that in 2010, we expanded the hub and spoke model and integrated into the pediatric subspecialty clinics. In 2014, the therapists became CCP employees. And then in 2014, we started expanding across the whole Western PA and did some other innovative things. So it became clear to me somewhere in 2012 to 2013 that, again, we were growing so fast that we weren't going to have enough child psychiatrists to meet all the needs, and that training had helped a little bit, that we were starting to get traction with the pediatricians. They were asking us to help them with the quality improvement initiatives, which was great, but we were also seeing that there was a need for kids that clearly didn't belong in our primary care system and probably did need a psychiatric eval, but we didn't have a system to do that. So like going to the therapist first might have actually been slowing them getting access to services. So in Massachusetts, they came up with a Massachusetts model, or the MC-PAT model, which is a way to get phone consultation with a child psychiatrist. And we were lucky that around that time, our state started to get interested in replicating an MC-PAT model in our system. So we call it TIPS, or the state calls it TIPS, the Telephonic Psychiatric Consultation Service. We call ours Children's TIPS. And this is a free service to have primary care clinicians deliver high-quality psychotropic services, and it's funded by the medical side of Medicaid. So the medical health plans in Medicaid each pay a per member per month fee for all of their members to have access to this service. And we're essentially available 9 to 5, Monday through Friday, to answer questions that they have about psychotropics or behavioral health. We really do talk to every doc. The average length of call is about 5 minutes. Some are less. Some are more. We have some frequent flyer docs that will call with really complicated questions. So they call, they get our care coordinator, and they'll say, like, a great example I have is one of our docs said, I think someone's diverting stimulants in my practice. Was a young doctor, and she said, and my lead doc doesn't agree with me and keeps prescribing Adderall 23 times a day. I need to figure out what to do. So we set up a time, and we had a 40-minute consultation. That is really rare, but I think it's a really nice service for this young doctor too, that was using sort of all of her training and now was up against some really difficult things. So we also do additional training. We do one in the north and one in the south every year. We'll go to every single practice. Any practice that invites us to come, we'll go at least once a year, if not more. If on the phone we can't resolve the question, so say, for example, someone calls and says, this child's at 72 of Concerta, the mom thinks this is anxiety, this is ADHD, but they're 10 and I'm feeling like going higher doesn't make a lot of sense, we can bring them in for some diagnostic clarification, help figure out what to do, and also recommend additional services and care coordinate for them to get additional services. So we're not just a phone line, but also helping them connect to the larger behavioral health system. We cover now 27 counties in Western Pennsylvania. It takes about, Pittsburgh's sort of in the middle of the purple or whatever that color that is there. It takes about 3.5 hours to get from there all the way up to the corner. So we've had to be thoughtful about how to do those direct consultations, and we've been using different mechanisms to do direct-to-home consultations. 2 weeks ago, I did my first one that I used a plug-in in our EMR to essentially activate something like FaceTime to talk to a kid that hadn't left the house almost at all in the last 2 months. So we're hoping we can see some changes in that and also be able to reach these rural kids that can't make it to Wexford or to even Erie, which is up in the corner of the state. This is the process, some of which I told you already. The doc can call the phone number, they get our care coordinator who gets some basic information, and then we consult via telephone about what to do. And then we can activate care coordination or a direct visit if needed. So this is our whole system at this point. I think I've told you about almost everything on here. So we have the hubs. It's 4 sites if you include our hospital. We have the 22 practices that have providers. The behavioral health and wellness clinics are our hospital-based integrated clinics. We have 4 nurse practitioners. Actually, we have 5. One site has 2 nurse practitioners that are behavioral health nurse practitioners working along with our psychiatrists and pediatricians in the community. We have the family care connection sites where we're training people to become, to work with young children. And then we have TIPS, which covers 27 counties. And we have a very robust consultation liaison service with both psychologists and psychiatrists, not unlike what you have here. So in 2013, my lead pediatrician came to me and said, AAP recommends that we screen for substance use starting at 11. And we have no idea how to do it. And he actually said, I'm not even sure I want to do it. But I feel like we need to. And there was a little bit of pressure actually from Children's Hospital as well, because it turns out there were several members of our board whose kids had had substance use problems. So a combination of AAP's recommendation and this like magical idea that we might get money from the board, which never happened, created a lot of momentum around the concept of substance use screening. I really felt honored that our pediatricians asked the behavioral health team to engage with them around. They didn't have to, right? Because substance use and it's screening in pediatric primary care. This is different than behavioral health. in terms of what a lot of people think about what behavioral health is. But I think we had built such a relationship up to that point that they trusted us. And they trusted that we wouldn't just sell them up the river to do something that didn't make sense. Because there was a lot of momentum and there was some concern about just more questions being added to the chart that wouldn't be useful. So after doing a review of the literature, we were lucky. We have some experts in substance use at Pitt. We decided to go for screening, brief intervention, and referral to treatment. And we actually called our SMART choices: screening, motivational interviewing, and referral to treatment, highlighting the importance of the motivational interviewing skills, which don't just apply to substance use, but apply to anything that pediatricians do if they're trying to get kids and parents to make different choices. And this is a collaboration of the behavioral health providers, the pediatricians, and UPMC Health Plan, with a little bit of funding from CVS and Conrad Hilton Foundation. So our mission, essentially our goal, is to improve health outcomes by helping adolescents make better choices regarding substance use. And I've begun to say everywhere I go, substance use is a pediatric condition. If you look at the number of people that die between 18 and 25 from substance use, it's appalling. And if we don't ask the questions, nobody else is going to ask them. And that gets some people uncomfortable. It gets me a little uncomfortable too. But I think it's important that we talk about substance as pediatric providers, and we talk about it just like any other health condition. You would know we ask about family history of lots of health conditions, but do we ask about family history of substance use? Probably not. Do I ask enough about it? Probably not. And what I've learned in doing this initiative is I think substance use is actually more stigmatized than behavioral health was, despite the opioid epidemic and all the talk. So the basics of the program is that we screen in 11 to 20-year-olds. We help them commit to cutting back, which is an action plan. And then our therapist will see them 2 visits in 3 months to complete a full evaluation with a focus on substance use, provide treatment of any comorbidities, because there's actually data that if you treat those comorbidities, you can improve their long-term outcome, and to follow up on the action plan. And then they're supposed to follow up on the primary care clinician in 3 months. We're still working on getting all those steps to happen, and I'm really using a motivational approach to this project. I told people I think this is like a 10-year project, really getting everyone to the point where we feel really comfortable with it. And the first step is screening. So in order to start screening, we found 3 prototype practices. Interestingly, the same practices that we had used 12 years before that were ahead of the curve. And they were so fearful of substance use, they didn't allow us to use the term pilot practice, because that implied that it might happen quickly and like get sent out to everybody in the practice. So we agreed on the term prototype because it sounded somehow like we had to work more issues out. And it took 2 years of us having iterative trainings and feedback sessions to get everybody up to the screening of 11 to 20-year-olds. So we started screening 13 to 17-year-olds. I went to every practice. I did feedback from every pediatrician in our 3 prototype practices. And what are you worried about? What do you need to do this? And not surprisingly, they were like, well, 11 and 12-year-olds, I don't get them alone in the room. And 18-year-olds, they might have real problems. So okay, let's start with 13 to 17-year-olds. The goal is that we will get to 11 to 20-year-olds because it's not going to be that bad. It is going to be okay. And they did it. And actually by the end of 2016, all of our practices had moved to the 11 to 20-year-olds on their own. We didn't even have to push them there because they realized it wasn't that bad. And we did consult some research and implementation experts about designing the screening tool. And the basic concept is you screen in well child exams. I actually pushed for all visits, but I didn't get that. There's some evidence to think that doing an all visits might be more effective, actually, because you might get more high-risk kids coming in with broken arms or things. But that was a little scary to a for-profit group to do a screening every visit. So low risk, you'd continue with your other wellness initiatives. Moderate risk, you do brief advice or brief intervention, refer to treatment as necessary, and high risk should really get a brief intervention, which is really coming up with an action plan, including seeing our therapist, unless they need to go to a higher level of care. And this is the screen we use. This is actually the NIAAA screen to the tobacco piece, and then tobacco down to illegal drugs is from our from data from our local researcher in substance use. If I had to do this again, and research from since then has proven this out. I would get rid of the pills and illegal drug question. If you look, S2BI, which is a national initiative related to screening, has shown you don't need to ask the question about pills and illegal drugs. You get really low response rates. And if you can identify the kids with alcohol and pot, you're in good shape. But our pediatricians are really invested in keeping those pills and illegal drugs questions, even though the like 0.1% positives we get. I often say, like, is that a sign that they're using or a sign that they're stupid? Because who would fill out that they're using illegal drugs, even an 18-year-old kid? Most of our screens are young kids, as you would predict, 11, 12, and 13-year-olds, because kids come less after they turn 16 to primary care. So in 2017, we rolled out the screening to the entire CCP practices, 11 to 20. We gave a webinar about SBIRT and the screen, and we gave what we call a one-pager, which is essentially something that the pediatricians could carry around with them or put in front of their computer that said how to do the screen. But we learned a lot from our prototype phase, and the screen really calculates everything in Epic itself. So they don't have to calculate anything, they just have to enter it. And we, through our learning collaborative, learned the best way to do that was to have the person that roomed the person enter the information. And then we also got access to an online training called Cognito that any doctor in the network could use. Although not surprisingly, we've had limited uptake from that. And interestingly, some of the doctors that have done the online training who aren't a part of our learning collaborative, which I'm going to talk about next, I got calls like right after they did that. This makes me more nervous. I don't know how to do motivational interviewing. I'm like, okay, we'll teach you. Just join the learning collaborative. So what also became clear is that there's more skills we all need to work on. So we have 2 to 4 practices every year doing a learning collaborative to learn more about SBIRT, motivational interviewing, and how to use the skills. And we give them MOC for the practices that participate. So the basic components of a learning collaborative is that it really is to improve the ability of the entire practice to implement brief interventions. It's a QI framework, and it trained the trainer model. So we do an in-person kickoff meeting. We systematically track their progress. There are monthly phone calls where the pediatricians actually help themselves move forward across practices. We do an in-person meeting where we spend like 3 hours just practicing motivational interviewing on things ranging from a combination of depression and anxiety with substance use to talking to a parent about how to let their kid get the HSV shot. Because these skills work for everything. Next time we're going to do, because one of our pediatricians suggested talking to parents about how to give their kids more fruits and vegetables. So, and then we do an in-person wrap-up meeting. So we have a great system at CCP with centralized oversight. So you can see, I think it was all the effort we put into as well, that our screening rates in well childs were fabulous. We got to 97% like that. Which is awesome. But we still have a long way to go because once you screen, you need to do something. So, and we also have some concern that the level of high-risk kids may be lower than it should be. This might partially be the population of the pilot practices, although I guess this is everyone. This may be people underreporting. We're going to dig into it a little bit more. And then I'm going to show you this slide because I think it's more telling. So once you screen moderate to high risk, you're supposed to do something. So BA is brief advice, brief intervention is doing a little bit longer, up to 15 minutes discussion and coming up with an action plan. If you look at when we started, everybody was between 20 and 25%. So quarter of the time documenting that you did anything after you identified a moderate to high risk patient. And you can see that top line is our learning collaborative practices. So by September, which is really recent data, they were up to over 50% of the time documenting that they did something. So it is just something. I can't tell you exactly what they're doing, but something's happening here. And there's more talk going on about how do we do more effective motivational interviewing and action plans for kiddos once they're at high risk. Oh wait, I went the wrong direction. Moderate to high risk patients that receive, so this is brief intervention. So this is a pediatrician saying, I really did an action plan and I did an evidence-based intervention. And you can see that people are really reticent to say that they've done behavioral intervention. I mean, our non-pilot practices are like around 10%, and I'm surprised it's even there. I think it's there because of how low the number of kids are that needed this. And probably we captured a few kiddos that were really high risk, like something had to happen that they needed to get immediate intervention. But you can see that in our pilot practices, something is happening, and people are documenting that they've done brief intervention more. We have more work to do, but something's going on. So when you roll out a screening to over 200 providers, you get some upset providers. So we had a great resident that was willing to do a survey to get some information about how people are doing and what they'd like to see. First of all, how important they thought SBIRT was, screening, brief intervention, referral to treatment. You can see they all thought that it was important. Less were confident and less were satisfied with what they were doing. And she also looked at barriers to providing screening and brief intervention. And I mean, I think the take-home point is that there's lots of barriers, and which ones can we impact? And this is how many primary care doctors said that they were doing something, so involving parents. This is also another thing we do with our learning collaborative. We have them practice getting the parents in the room, because that's what really makes people anxious. Essentially, that complicated last slide came down to 4 things people wanted. They wanted a parent handout, more MI training, they want a clinic poster, and they wanted a care coordinator. So we can't provide all of those, but we're actively working on a parent handout that's more attuned to what a pediatrician's need is. Our nurse care coordinator spent a long time going through everything available on the SAMHSA website, on NIH and NIDA, and nothing is really, not even the AAP stuff, which was sort of surprising to me, addressing this sort of anticipatory guidance stuff that really is what a pediatrician does in these younger kids. There's a lot of stuff about opioids. There's even a lot of stuff about crack from the 80s. Also, not a lot about pot, which we're staying out of directly, but is a big deal. And in fact, the trainings that we've done, I've made a point about talking about pot, because I've been impressed. The other sort of tagline I have people say is, it's not your grandparents' pot anymore. Like, this is different than even what any of us may have experienced or not experienced when we were younger. So things have changed. And if we as primary care doctors, as psychiatrists, can't stand up and say, this is not good for the developing brain, who is going to do it? Nobody's going to do it. So this is a lot of stuff on this, but these are like my questions about where do we go next? How do we develop a workforce that can really do this in primary care? Both the pediatricians, the psychiatrists, and the therapists. The need for really therapists that are generalists. This is a fast-paced job, as you all know, as pediatricians. It's different than what therapists are used to. What's appropriate for primary care, or is that even the right question? Who should take care of the sickest patients, and should we be thinking about reverse integration for the kids that really need something else, like the severe ID kids with that need more help than maybe even a primary care doctor should provide, and then new reimbursement mechanisms, because we're still fee-for-service predominantly in Western PA. So although there's talk of population health, we're not quite there, and no one's putting their money where their mouth is. That's my child in the middle. But essentially, I think that working in primary care and working in all of medicine is like playing in someone else's sandbox from a psychiatrist perspective. And if you don't pay attention to the tools everyone brings, the expectations people have, you don't work on the systems and like pay a sense to the personalities, it won't work. And it's like playing in a sandbox. You need to play by everybody needs to play by each other's roles. So thank you for your time.
I think we have a few minutes for questions. Does anyone have a question?
Thanks for a great presentation. Could you say a little bit more about the therapists, what their training is, where you get them from, how much they get paid, so forth?
I can say that off the top of my head, I don't know how much they get paid, but I can speak to other things. So they're all LCSWs. We have some LPCs. In pediatrics, you can get LPCs reimbursed. In geriatrics, you can't, because Medicare doesn't pay for LPCs. Just as an aside, for anybody who's thinking about LPCs, that's a licensed professional counselor. We had an LMFT once. So essentially, anyone that's a licensed clinical provider And that's an additional amount of training once they finish their training. Sort of similar to our residency, except they don't get paid for it, and a lot of people have to pay for the supervision they need in the 2 to 3 years post-training. But when we bring them in to interview, and I was just talking to somebody yesterday about this here, we really focus on a few things. One, they need to have the training. But once they've had the training, are they flexible? How are they at communicating with people? And how good are they at diagnosis and understanding some basic psychiatric concepts about suicide, suicide evaluation, and safety? Does that answer your question?
Graduates of universities?
Yeah, they're mostly local. We take very few people right out of school. I think you need a little bit of experience first before you go in, because they're really going to go in, and we tell this to people. You're going to go in there and you're going to be the behavioral health expert with a pediatrician, and that's scary to people right out of school that are not MDs or DOs or APRNs. So usually we get people 4 or 5 years out of school. Our biggest recruitment tool is word of mouth, actually, from people that have been in our service and then get their friends to come join. Yeah.
You had mentioned the importance of the for-profit nature of the practices, and that the psychiatrists were actually hired into the practices, but your therapists are hired centrally. And I'm curious about the payment structure for the psychiatrists. Are they on the same payment structure as the pediatricians, like production versus salary, et cetera?
So currently, our therapists are employed by the practices. And they're entirely employed by the practices. And the psychiatrists are employed by the Children's Hospital. Psychiatrists lose, well, a lot of us are Western Psych, but the Children's Hospital pays for our time, as we all know how that works. So psychiatrists lose money. It's like a well-known fact, unless you do 15-minute med checks, which we felt that we didn't want to do, especially to help support the pediatricians. So our practices actually make money on our therapists and pay in to the centralized structure to support administration, oversight, and psychiatry time.
I think we need to wrap up. Join me in thanking Dr. Schlesinger. Did I say that right?
Yep, that was good.
Close. And next week, we will not be here. Hopefully, everyone will be thinking of eating turkey and thinking about what we're grateful for. We'll see you in 2 weeks.